You know, um, Usually when we talk about a medical diagnosis or like a clinical procedure, there's this expectation of visual precision.
Right, yeah, like engineering.
Exactly. It feels like engineering.
Yeah.
If you break your arm, you go to the hospital, the x-ray shows that jagged white line on the screen, and the doctor just points at it and says, there is the problem.
It provides this sense of binary comfort. The issue is visible, it's perfectly categorized, and the solution is straightforward. You just set the bone and put a cast on it.
But then you step into the modern world of regenerative medicine, specifically sexual wellness, and suddenly that x-ray machine is completely useless.
Totally useless, yeah.
We are looking at a clinical landscape where highly sensitive procedures are being performed on the most delicate microscopic tissues in the human body, relying entirely on invisible chemical reactions. So welcome to today's deep dive.
We have a really fascinating stack of sources to get through today.
We do. A massive stack of sources in front of us, including medical case reports, clinical pharmacology studies on local anesthetics, spanning all the way from dentistry to gynecology,
Hmm.
and exact clinical protocols for a regenerative sexual wellness procedure known as the O-shot.
The literature here is just incredibly detailed. It really bridges the gap between abstract cellular chemistry and very practical patient outcomes.
And our mission for today's deep dive is to answer a highly specific but fascinating medical question for you, the listener. We're going to figure out exactly how doctors can perform an injection into one of the most sensitive parts of the human body without causing immense pain.
Right.
Specifically, we're going to uncover the exact chemical buffering ratio used to neutralize the notorious sting of lidocaine nerve block used during the O-shot.
Which is such a brilliant lens through which to view modern medicine, because this question, it sits right at the intersection of biology, pharmacology, and, well, patient comfort.
So let's unpack the baseline first. For anyone who might not be familiar with regenerative therapies, the O-shot, or orgasm shot, is a procedure designed to treat urinary incontinence and improve sexual function in women. But before we get into the pain management, what is the actual physical mechanism of this? Like, why are patients seeking this out?
The premise basically centers on using the body's own healing mechanisms to rejuvenate tissue. So the clinical protocol starts by drawing a small sample of your blood, much like a routine lab test.
Okay.
That blood is placed into a centrifuge, which spins it at high speeds to separate the red blood cells from the plasma. The ultimate goal is to isolate platelet-rich plasma, commonly referred to as PRP.
Like PRP. I hear about PRP a lot in sports medicine, like for knee injuries, but what is it actually doing in this context?
It's the same principle. Platelets are the cells in your blood that rush to the site of an injury to initiate healing. They are packed with growth factors.
Right.
When isolated in high concentrations and activated, usually by adding a little bit of calcium chloride, this PRP can stimulate angiogenesis, which is the formation of new blood vessels, and neurogenesis, the growth of new nerve tissue.
Okay, so the doctor has this highly concentrated, activated healing serum. The next step is getting it where it needs to go. And just reading the clinical terms for the injection sites in our sources made me tense up.
The protocol outlines injecting this PRP directly into the tissue of the clitoris and the upper vagina.
Wow.
Yeah. Specifically, a portion of the fluid is injected into the O-spot, the space between the urethra and the vaginal wall, while another portion is injected directly into the clitoral corpus cavernosum.
Okay, let's translate that last term for anyone not looking at an anatomical chart right now. What exactly is the corpus cavernosum?
It is the internal sponge-like erectile tissue of the clitoris. Structurally, it's incredibly dense with blood vessels and an exceptionally high concentration of nerve endings. We are talking about arguably the most delicate, hyper-responsive tissue in the human body.
So combining the idea of a medical needle with that specific tissue sounds absolutely terrifying.
Oh, absolutely.
I mean, I initially assumed, reading through this, that a patient would need general anesthesia like being fully knocked out for something that sensitive. But the case reports and patient surveys in our stack consistently show patients rating the procedure as virtually painless.
It's quite remarkable.
Most rate the discomfort as a 1 or 2 out of 10 or say they feel absolutely nothing. I honestly thought maybe the nerves in that area just don't register puncture wounds the same way skin does.
That would be a logical guess, but those nerves are actually hyper-responsive to any stimuli, including a needle puncture.
Oh, all right.
The lack of pain is entirely due to a highly engineered two-step numbing process. And the real story here is the massive chemical hurdle doctors have to overcome during step 2 of that process.
Well, let's start with step 1 then. I imagine they must use some sort of heavy-duty topical cream before the needle even comes close.
Yeah.
Is it similar to the over-the-counter numbing sprays you might use for a bad sunburn?
Oh, it is significantly more potent than anything available over the counter. Our sources detail a custom compounded topical cream designed to heavily depress surface sensation.
Wasn't it?
The standard formulation used in these protocols contains 20% benzocaine, 8% lidocaine, and 8% tetracaine. The physician applies this thick cream to the clitoris, the labia, and the anterior vaginal wall, and allows it to sit and absorb for about 20 minutes, often applying an ice pack over it to further dull the nerve responses.
Okay, so that numbs the surface to prevent the patient from feeling the initial pinch. But I imagine a cream, no matter how strong, can only penetrate so deep. It can't possibly reach down into the erectile tissue to numb it for the actual PRP fluid expansion.
Exactly. That is the fundamental limitation of topical anesthetics. They are excellent for the mucosal surface, but to achieve profound numbness deep within the corpus cavernosum, the physician must perform a nerve block.
Right.
This involves using an ultrafine needle to inject liquid lidocaine directly into the deeper tissue space,
Yeah.
essentially bathing the nerves in the anesthetic.
And this is where I hit a massive contradiction in the source material. Lidocaine is the ultimate medical painkiller, right? But if you talk to anyone who has had a standard lidocaine injection at the dentist, or like having a mole removed at the dermatologist, the injection itself hurts.
It really does. Patients routinely describe the injection of unbuffered lidocaine as a severe, burning, stinging, tearing sensation. It's an incredibly intense, localized pain.
So I have to ask, if lidocaine is specifically designed to stop pain, why does the chemical itself feel like it's burning you from the inside out the second it hits your tissue? I used to think the pain was just the physical pressure of the fluid stretching the tissue.
The pressure contributes a small amount, sure, but the intense burning sensation is almost entirely chemical. To understand why it burns, we really have to look back at the history of local anesthetics and why lidocaine is formulated the way it is today.
Okay.
If we rewind to the early 20th century, the primary local anesthetic in dentistry and surgery was Procaine, which most people know by its brand name, Novocaine.
Wow, I haven't heard the word Novocaine in years. My dentist always uses lidocaine now. Why did we switch?
Novocaine had significant drawbacks. It took a long time to take effect, the numbing didn't last very long, and because it was an ester-based anesthetic, a surprisingly high number of patients experienced severe allergic reactions to it.
Oh, yikes.
Yeah. Then, in the 1940s, a Swedish chemist synthesized lidocaine, which belongs to a completely different chemical class called amides. Lidocaine was a medical revelation. It acted faster, penetrated deeper, lasted longer, and carried a much lower risk of allergy. It quickly became the global gold standard.
But creating a miracle drug in a lab is only half the battle. You still have to bottle and ship it to clinics around the world.
Which introduced a major logistical challenge: stability. Pharmaceutical companies needed lidocaine to survive sitting on a clinic shelf in a glass vial for months or even years without degrading.
Right.
Through testing, they discovered that lidocaine is highly unstable in a neutral liquid, but it remains incredibly stable if it is packaged in an acidic environment.
And that brings us to the pH scale. Standard commercially available lidocaine is manufactured to sit at a pH of about 4.2. Let's give that some context for the listener. The pH scale runs from 0, which is battery acid, to 14, which is liquid drain cleaner. 7 is perfectly neutral water, so a pH of 4.2 is definitely leaning heavily into the acidic territory.
It is. Now, compare that 4.2 pH to the environment it's being injected into. Human subcutaneous tissue, the delicate layer of fat and connective tissue right under your skin and mucous membranes, maintains a very strict neutral pH of approximately 7.4.
And since the pH scale is logarithmic, every single number jump represents a tenfold change in acidity. So jumping from a 7.4 tissue environment down to a 4.2 lidocaine fluid means the anesthetic is roughly 1,000 times more acidic than the body it's entering.
Which triggers an immediate, aggressive physiological response. When that highly acidic fluid hits the delicate nerve endings in the clitoris, it causes acute chemical irritation. Your body sounds an extreme alarm that an acid is attacking the tissue. This happens instantly, long before the numbing properties of the drug actually have time to bind to the nerve receptors and shut those alarms off.
It's literally the equivalent of getting a paper cut and deciding the best treatment is to aggressively squeeze fresh, highly acidic lemon juice directly into the open wound. The tissue's screaming.
The patient is experiencing a localized chemical burn. So, if a physician is preparing to perform a nerve block in one of the most sensitive areas of the human body for an O shot, they cannot simply pull standard lidocaine off the shelf and inject it. They have to alter the chemistry of the drug before it ever touches the patient.
Which brings us to the core of this deep dive, the buffering process. The clinical protocols detail a step where the doctor essentially plays chemist right there in the clinic room. Just before the injection, they take that acidic lidocaine and mix it with a neutralizing agent, specifically 8.4% sodium bicarbonate.
Which is a sterile, liquid, medical-grade formulation of baking soda.
Because baking soda is highly alkaline. By mixing an alkaline base into the acidic lidocaine, it neutralizes the acid, dragging that harsh 4.2 pH all the way up to match the body's natural 7.4 pH. When that pH-balanced fluid enters the tissue, there's no chemical clash. The lemon juice effect is completely neutralized.
Exactly.
But what fascinated me most in these sources is the extreme precision required for this step. You can't just eyeball it and squirt some baking soda into the syringe. Across all these clinical fields, from pediatric surgery to dermatology to the O-shot protocols, the focus is on a very specific recipe.
The clinical ceiling is universally recognized as a 9-to-1 or 10-to-1 ratio.
Let's make sure the mechanics of that are crystal clear. Does that mean if a doctor is preparing the syringe, they're drawing up 10 parts of lidocaine to just one single part of sodium bicarbonate?
That is the exact protocol. A physician might take a standard syringe, draw up 10 milliliters of lidocaine, usually a 1 or 2% concentration, and then draw up exactly 1 milliliter of the 8.4% sodium bicarbonate into that same syringe.
Okay, I'm going to challenge the logic on this because human nature dictates that if a little bit of something solves a problem, a lot of it will solve it permanently. If the ultimate goal is to absolutely ensure there's zero acid left in that syringe to burn the patient, why stop at a 10-to-1 ratio?
Right, why not more?
Yeah, why not do a 5-to-1 ratio? Or just go half and half and make the solution super alkaline just to be completely safe.
Pushing the pH higher seems logically sound on the surface, but in practice, it would be a catastrophic clinical error. The FDA package inserts and decades of pharmacological studies explicitly warn against overbuffering. That 9-to-1 or 10-to-1 ratio is a strict chemical ceiling for a reason.
What actually happens if a doctor messes up the math and adds too much bicarbonate?
If the pH of that solution gets pushed too high specifically, if it crosses above a pH of 7.8, the lidocaine molecules become completely unstable in the fluid. The solution physically changes in a process called precipitation.
Precipitation, meaning it turns from a liquid back into a solid.
Basically, yes. The clear liquid in the syringe will suddenly turn cloudy, and the lidocaine forms microscopic crystals. If a physician attempts to inject that, several things go wrong. First, those tiny crystals can easily plug the ultrafine needle required for sensitive procedures, physically jamming the syringe.
But what if it doesn't jam? Like, what if that cloudy fluid makes it into the tissue?
If the crystallized fluid enters the tissue, the drug is no longer in a chemical state where it can effectively bind to the nerve channels. The numbing block will simply fail. More alarmingly, injecting a precipitated, overly alkaline solution creates immense cellular stress, which can cause severe tissue irritation and ultimately lead to necrosis.
Necrosis, meaning the cells in the tissue literally die off.
The tissue can turn black and die. So in a highly vascular, vital area like the clitoris, overbuffering is incredibly dangerous. Physicians must adhere strictly to that 9-to-1 or 10-to-1 ratio. It strikes the perfect chemical balance, neutralizing the acid just enough to match human tissue at 7.4 without crossing into that 7.8 danger zone.
The level of precision is astounding. But as I was reading deeper into the pharmacology studies in our stack, I found something that completely blew my mind. This precise 10-to-1 buffering ratio doesn't just act as a comfort measure. It isn't just there to stop the burning sensation. It actually makes the lidocaine work dramatically faster and more effectively.
Yes. It triggers a fascinating physiological phenomenon known as diffusion trapping. And to understand why this creates such a profound nerve block, we have to look at the microscopic structure of human nerves and how molecules cross barriers.
Okay, I'm picturing a nerve like an electrical wire, with a nerve sheath acting as the rubber insulation around the outside.
That insulation, the outer membrane of the nerve cell, is primarily composed of a lipid bilayer. It's made of fats. Now, when lidocaine is in its standard, acidic, unbuffered state in the vial, the molecules are highly ionized, meaning they carry an electrical charge. Charged molecules are water-soluble.
And as we all know, oil and water do not mix.
Exactly. When those water-soluble, charged lidocaine molecules hit the fat-based nerve membrane, They struggle to cross that lipid barrier. They literally bounce off. It takes a significant amount of time for the molecules to slowly push their way through the membrane to reach the inside of the nerve, which is where they actually need to be to block the pain signal.
Which explains the agonizing wait in the dentist chair while your jaw is burning from the acid and the doctor's just waiting for the numbing to finally kick in.
Precisely.
Okay, I want to try an analogy here to visualize this. Think of the nerve cell like a really exclusive, high-end nightclub. Unbuffered lidocaine is like a massive crowd of people stuck outside in the freezing cold. They're water-soluble, but the club only accepts lipid-soluble. They completely fail the dress code, so they're just stuck waiting in a miserable, slow line, hoping the bouncer lets them in one by one.
Let's build on that analogy because it's perfect. When the physician buffers the lidocaine by adding that 1 part sodium bicarbonate, a major chemical shift happens based on a principle called the Henderson-Hasselbalch equation. The lidocaine molecules convert from that charged water-soluble state into an uncharged lipid-soluble base.
So suddenly, the entire crowd waiting outside the club gets handed VIP outfits. They suddenly match the dress code perfectly.
Because they're now lipid-soluble, they can slip right through the fat-based nerve membrane with virtually zero resistance. But the buffering process introduces another critical element that acts as a catalyst. When you mix the acidic lidocaine and the alkaline bicarbonate, a chemical reaction occurs that creates 2 byproducts, water and carbon dioxide.
Carbon dioxide, CO2, like the carbonation bubbles in a soda.
The very same. And this CO2 is the secret weapon of the 10-to-1 ratio. Studies going back to a clinical researcher named Kachlov in 1972 demonstrated that this newly formed CO2 rapidly diffuses straight through the nerve sheath. Because it's a gas, it moves incredibly fast, reaching the inside of the nerve axon before the heavier lidocaine molecules even get there.
So the CO2 races ahead of the lidocaine to the inside of the nerve. What does the gas do once it's inside?
It instantly lowers the pH of the interstitial fluid inside the nerve. It makes the interior environment acidic. So when those newly uncharged lipid-soluble lidocaine molecules slip inside the nerve and hit that acidic environment, they instantly become charged again. They revert back to being water-soluble.
Wait, so they change form again, which means they can't get back out.
Exactly. Because they're charged again, they can no longer pass through lipid membrane to exit. They are trapped inside the nerve. That is the essence of diffusion trapping.
That completely elevates the nightclub analogy. Adding the bicarbonate doesn't just change the dress code for the crowd. The chemical reaction creates a VIP bouncer, the CO2. The bouncer runs ahead, sneaks through a side door, and alters the environment inside the club. Then, the bouncer pulls the lidocaine VIPs directly into the club, and the second they step inside, the environment changes. The door locks behind them, and they cannot leave. They are trapped inside the club, immediately shutting down all the pain signals from the inside out.
It creates profound, nearly instant analgesia. By utilizing that specific 10-to-1 buffering ratio, a physician eliminates the acidic tissue burn, speeds up the onset of the numbing, and traps the anesthetic right where it needs to be for a deep, complete block.
Which completely answers the mystery of our deep dive today.
Yeah.
That is exactly how a patient can have a needle injected into the clitoral corpus cavernosum and rate the pain as a 1 out of 10.
Yep.
It's not magic, it isn't an unusually high pain tolerance, and it isn't just a really strong topical cream. It is precisely calculated chemistry.
The difference between a traumatic medical experience and a comfortable, seamless one often hinges on a physician's deep understanding of these microscopic interactions. Simply purchasing the anesthetic isn't enough. A doctor has to know how to adapt the chemistry of the drug for the biological reality of the human body.
Let's bring this all together and summarize what we've unpacked today for you, the listener. The reason a procedure as seemingly intimidating as the O-shot can be performed virtually painlessly relies on a 2-step process, but the heavy lifting is done by an incredibly specific chemical recipe.
The universal standard of mixing 9 or 10 parts of lidocaine to exactly 1 part of 8.4% sodium bicarbonate.
That precise 10-to-1 ratio neutralizes the harsh acid needed to keep lidocaine shelf stable, bringing it up to a tissue-friendly pH of 7.4. That completely stops the infamous pre-numbing sting. Furthermore, adhering strictly to that 10-to-1 ceiling prevents the horrifying prospect of tissue necrosis that comes from overbuffering past a pH of 7.8. And on top of all that, it utilizes the chemical byproduct of CO2 to create diffusion trapping, tricking the nerve into pulling the anesthetic inside and locking the door behind it.
When you understand the underlying mechanism, the anxiety surrounding sensitive medical procedures really starts to dissipate.
It replaces the fear of the unknown with a genuine appreciation for the science. But I want to leave you with a final thought to mull over as we wrap up. We've just spent this time exploring how precisely manipulating the pH balance of a single fluid can essentially trick a nerve into lowering its defenses and shutting down completely.
Hmm.
If our nervous system is this highly rapidly responsive to highly localized shifts in acid and base chemistry, could the future of chronic pain management rely less on inventing stronger, highly addictive pharmaceutical drugs and more on discovering new ways to alter the micro-pH environment around our pain receptors to simply turn them off naturally?
That opens up an entirely new frontier of thinking about how we interact with the body's native environment rather than just the chemicals we introduce to it.
It really is something to think about next time you reach for the baking soda in your pantry. Just remember, whether it's avoiding the sting of a needle or skipping the line at a nightclub, it is all about having the right chemistry.